Hello, everyone. Welcome to our town hall. We are from Rochester Institute of Technology, and as part of our Rural Communities Opioid Response Program, or RCORP grant, we are holding a town hall focused on working with vulnerable populations. So this will focus on some key issues and just a disclaimer that this project is supported by HRSA. Again, as part of our grant, the contents of this town hall are the opinions of the three of us and do not necessarily represent the government nor HRSA. So just a brief introduction to what we'll cover today. So we will introduce ourselves, talk about some common concerns, some issues to be aware of for working with different populations, some suggested responses to meet these issues. And then we will provide some materials that you could use for further exploration. And with the remaining time, we'll just discuss some complex issues and perhaps some scenarios. Okay. So we'll start with our introductions.
Hello, everybody. My name is Dr. Celeste Sangiorgio. I'm a licensed clinical psychologist, and I teach at Rochester Institute of Technology. And my expertise related to what we're talking about today is I've worked in different forensic settings. So I've done competency to stand trial. I also teach forensic psychology. And I also ran a free clinic along with Courtney for people experiencing homelessness. And in that population, sadly, because it is overrepresented, we had people with severe and persistent mental illness, as well as substance use issues, and people who were involved in or court involved. So I will pass it off to Dr. McKinney to introduce herself.
Hi, everyone. I'm Courtney. So I work at Rochester Institute of Technology also. I am a licensed clinical psychologist. I do research on digital therapeutics and provide clinical care for clients with substance use disorders. As Dr. Sangiorgio mentioned, clients experiencing homelessness, severe persistent mental illness, and a variety of additional issues.
Hello, my name is Hasad. I'm a postdoc with Rochester Institute of Technology, and I work in substance use disorders and forensic settings.
Wonderful. Okay. And I am going to go ahead and share the next slide. And I believe I'll be taking over here. Is that correct, Dr. McKinney? Okay, wonderful. So we're going to start with covering some common issues and concerns when working with this population. This town hall is designed, initially we're going to do it as a participatory town hall, but we adapted it so that people could engage with it in a time frame that best matches their own availability. And so feel free to pause it at any point, read, and we're going to kind of move along in it. And so this first section you can think of as or the way that we conceptualize this is that it's different issues that you'll see across different populations. So you can think of these as transdiagnostic issues. They're not connected to a specific diagnosis. They are issues that can present in different contexts, different situations with patients, and with different issues that they come in with. And so what does that mean? We have patients might these are things that disrupt your ability to work with patients. So one of those things is invalidation. And first I'm going to go over each one. The next is stigma. So this might interrupt your ability to work with patients if they're experiencing stigma. And then the third is some patients need some normalizing in the symptoms that they come to you with as a clinician. And so what are each of those? What are the definitions that we provide? Invalidation, it could be, it's anything that ruptures the relationship. The patient comes to you with something, there's a mismatch in their expectation, and then there's a rupture there. These could be micro invalidations. I'm going to go into a better or deeper definition with some examples on the next slide. Stigma we have defined as barriers to sharing. So these are maybe cultural norms, different things that make it hard for them to share what they're experiencing. And if they can't share it, then you can't work on it with them, right? And then the last is a need for education and a need for you as the clinician to contextualize what they're experiencing. So maybe they are worried or concerned about what they're sharing, and they can really respond effectively if you normalize, people come in with these types of symptoms. And you might notice that these kind of weave into each other, and they very much so do. Okay, so what I have on the left-hand side of this slide are examples of each of the things and then a response. So first we're going to go over the examples. So for invalidation, this could be, a patient can come up to you with weight issues or mentions a partner, and you make an assumption that is a mismatch between what they expect. So, if a patient's concerned about their weight issues and you say you look great, then that could kind of make them pause and be uncomfortable, and then that shuts down their ability to share with you. And you can see there's more examples there as well. That last one is something that I personally have seen in therapeutic environments. So I think we can sometimes get very casual or used to asking people about suicidality, and then we forget how intense of an experience that is to share. And so it could be very invalidating when someone shares for the first time that they were suicidal. It could be the first time they're ever saying that to someone. And then if you say kind of great, thank you, and move along in your assessment, then that could be invalidating and shut down their ability to share with you because they don't feel safe anymore sharing. The next example we have is stigma. So stigma is discomfort, difficulty, maybe because of cultural norms in sharing with a clinician. And so in this situation, these examples, they're extreme kind of reactions by the clinician, or they are something that makes them feel worse or increases their pain when sharing. So we have here as an example, if someone says something and you're like, oh, wow, oh my gosh, some intense response like that, that could reinforce that stigma that they feel. The other example here is saying you lost your kids because you never got sober. So that feels like a judgment, and that kind of feeds into that stigma. The next example we have here for not normalizing is, sorry, I'm moving things around in my slideshow so I can better see it. We have, I've never heard something like that before, or that's so much money to spend on alcohol. The second example, if you work in substance use, one of the common assessments is to ask people how much they spent per week in order to make it concrete. So if you say something like, oh my gosh, that's so much to spend, then not only are you can see it's the stigma example as well, but you're also, you're focusing on the symptoms in a way that takes attention off of moving towards a treatment plan. So it's very common when people have addictions to spend a lot of money on them. It's one of the reasons that we ask them about that. And so once you get that concrete information, then that's really helpful for moving towards a treatment plan. So I'm going to go into the responses on the right-hand side. And so the response to invalidation is to increase opportunities for learning. So what does that mean? That means creating different situations in which the patient can self-inform you. So that might be front desk staff can ask questions, can gather information about how people self-identify or what they want to focus on. It could be questionnaires. And it's also using as much neutral language as possible until a patient provides what their language is. So I have here your husband as an example. So someone might, when they mention a relationship, it might not be their husband, it might be their spouse, their partner, their child's father. And so creating or just using neutral language creates more opportunities for someone to educate you on what terminology is appropriate. For stigma, asking specific questions and including specific or allowing the patient to respond. So this would be asking open questions. And for not normalizing, the response is to allow patients and support patients as being experts in their own lives. So they're an expert in their own life. They know what's happening. They know what they're coming in to work on. And as a clinician, we can meet them as an expert in the medicine that we're providing for them. All right. So here, and what I like to do here when it's a asynchronous presentation or a presentation that people can move at their own rate, what I like to do is suggest on the bottom right-hand side, you'll see a time. So if you want to do this reflection or discussion on your own, feel free to pause it for 5 minutes. If not, we're going to talk too. So we're going to do this reflection and discussion together. But take your time as you want. So I'm going to read it and then we're going to talk about it. So the first is the first part of this reflection is asking yourself, was there a time when you were particularly aware of one of these issues, remembering that these issues are invalidation, stigma, or need for education? And then the second part of this question is, what happened? What did you notice? And how did you feel during when it was happening? And what happened after? All right, so I will open it up and I can also share first if you want. So do you guys want to jump in first or should I share?
You can go ahead if you want.
All right. So I know I included a bunch of examples in the previous slide, and one of the reasons I did that is because these are things I've experienced. So I worked for some time in the Safe Horizons hotline. So that's for sexual assault, intimate partner violence. And so we had a bunch of cases like that. And I've seen people kind of assume relationships. And so, someone says that they are having an issue with someone they're cohabitating with, and someone just assumes and uses the term partner or husband or boyfriend. And then that patient has to correct the clinician and say, oh, actually, that's my child's father. Or, sometimes they have a really strong reaction too, like, they're disgusted by the idea of a relationship with that person. And what I noticed is, like I said before, it could be very invalidating, right? That patient really doesn't feel recognized. They feel pressure to educate the clinician about what's happening in their home. And it also contributes to stigma too. So they are aware that if a clinician makes that assumption, then they might assume, like they might feel that someone who's cohabitating is like naturally dating or with someone. And so it takes a lot of energy and time in a very time-limited context, and focuses it in an area that's not productive if you're trying to get someone towards treatment. And for the clinician, it's uncomfortable too. But it's also an opportunity to learn because
Yeah, it's a good
definitely
example.
asking open questions after that. Yeah.
One that I've seen is when someone mentions a same-sex romantic partner, and then later the clinician refers to that person as gay, and the client says, oh, I'm not gay. I happen to have a same-sex partner right now. And the clinician realizes they made an incorrect assumption. And that's a good opportunity for self-education and learning more.
Yeah, those are great examples. A couple that I can think of, I will say, just to be honest, as a clinician, sometimes initially my internal thought might be one of invalidation. So, for example, I've had a client talk to me about something that was upsetting to them. And in my head, I was thinking, oh, that's not really a big deal. Like, why would you get upset about that? I'm able to pause and not say that out loud, but I think sometimes our natural tendency might be to share a statement like that. And that can be very invalidating because even though we might not see it as a big deal, it was obviously something bothersome to that client. So I think it's good to be honest with ourselves that some of these, are just natural reactions, and being more educated and taking the time to just take a quick moment to think about our response can be helpful. Another one that I can think of, having to do with the need for education. And it also ties into stigma, is I've worked with family members of clients who have substance use issues, and the family members get very angry, and sometimes they're ashamed to admit that. Like, I just lost my temper. I just yelled at them because I'm so frustrated. And so I think there's this stigmatization, like they feel bad about getting upset, like it's the wrong thing to do, but also brings in the need for education to let them know that it's normal to feel this frustration. This is very common, and, talk through that.
Those are such good examples, and I really I hope that it helps with, people watching this later. It helps with guiding their own thinking about either. I know that the town hall is both for clinicians as well for people's family members, and so and also people experiencing substance use, however it touches their lives. And so one way to reflect is to have this question and then pause, and then another way to reflect maybe would be to bounce off of some of what we were talking about too. All right, so let's move. How do you guys feel about moving into the next section? Okay, cool. All right. So this next section is responses to different responses to common issues, and we're going to focus on micro skills as well as specific techniques. And so we're going to be passing it off back and forth. And so I'm going to first give you what we'll be focusing on in each section. So the first one is different opportunities for patients to inform the clinician, so how to build out those opportunities. The second is reflections and summaries. So these are really like straightforward key skills, and with examples on how to do them. And then the next one is education. So how to provide a situation in which the patient can educate you, as well as you as a clinician, where to go and educate yourself so that you can best meet these patients effectively. Okay, so we're going to go to the next slide now, and I'm going to pass it to Hasad here.
Yeah, thanks. Here's an example of an inclusive questionnaire about gender identity that you can use for all clients at intake. I think this questionnaire helps avoid trying to find a comfortable way to address issues of identity, because it provides all clients at the outset, and they can simply be reviewed during the first session. Okay. Here are some examples of using both direct and indirect communication in the clinical setting. Direct communication could consist of letting the client know that we welcome correction regarding labels and identity. For example, I might say, I will use terms like X and Y. However, I recognize that is not the terminology that everyone uses. Let me know what is best for you so that I can be as accurate as possible. Or I might simply ask, what pronouns should I use for you? Indirect communication might make use of built-in pauses. As such, when listening to a client discuss when they first became aware of their mental health symptoms, I might ask, and who noticed that symptom? Okay, your partner noticed that you had that symptom. Resisting assumptions can help create space for clients to self-identify. When possible, try to avoid leading language, because this can imply a direction for a client's response, even if it's not our intention.
Wonderful. Thank you.
So when we are reflecting and summarizing, this can take a variety of manners, varying from very open responses to ones that are more closed and pointed. So just we'll summarize here on this slide some of the skills, and then Dr. Sangiorgio will provide more specifics on these. So one of the most open things to start with is attending behaviors, then some simple reflections, more complex reflections that tie some of the client's thoughts together, open-ended questions, then more probing questions. And sometimes we need to be very direct and provide questions that have multiple choices or true or false answers. So Dr. Sangiorgio will provide some examples of these.
Wonderful. Thank you so much, Dr. McKinney. Okay, so the way that this is structured for this next section is there's a table, and you're going to see 2 pages of this where the top part are the more open questions and the bottom is the closed, but I'm going to walk you through each one, first describing what the thing is, then the idea and an example. I'm going to go fairly quick, and then we have a video demonstrating some of these techniques, which if you're watching this asynchronously, feel free to, we're going to call out a certain part of that video. You can watch the whole thing. You can just watch none of it, or you can just watch pieces of it. So the first example we have here, as Dr. McKinney mentioned, is attenders. And so an attender is the most open thing that you can do because it's just doing a small gesture to encourage the person to continue talking. So that might be something like nodding along, or I know that you can see us in the corner, so that could be like, opening your hands like that. And it's also things like saying, okay, right? So there are nonverbal, so kind of body language cues to continue talking, as well as verbal ones. And so this really just shows the person that you're listening and you're interested in them continuing. Then the next thing that's a bit more closed but still quite open are simple reflections. And so in simple reflections, you're very, very simply just repeating back what someone said. So the example, and you're doing that in maybe your tone or your pitch or the way you say it encourages that person to continue talking. So someone might say, I just feel alone. You're like, so you feel alone, right? So you can see there the pitch kind of encourages them. You feel alone, with a kind of ... and they continue talking. After that, complex reflections are a bit more closed because they lead a person in a way to continue talking and opening up. So what you do in a complex reflection is you repeat back 2 ideas that someone shared and you emphasize their connection. And a rule of thumb, kind of a little trick with complex reflections is you put the thing that you want them to continue opening up about or talking about second. So I have an example here for that person before that said that they felt alone. You can say you feel alone, but you also worry about feeling lonelier without a routine. Right, so if I phrase it that way, if I connect those 2 ideas, assuming the person said something about a routine, then it might be that I'm curious about what it is about their routine that they are concerned about, that they might see as a barrier or a success, right? So I just want to know more about the routine, so I put that second. Okay. There's 4 more examples here. Again, we're going from open to closed. The next one is open questions, and open questions are anything that can't be answered as a yes, no. So I have an example here. And how did you know that your partner was worried about you? So you can see the how is what makes it open. A good rule of thumb for open-ended questions are saying like how, which, why, and what. Right, so if you are having a hard time coming up with an open question, that's a good way to start, is to just start with one of those stems and then connect it to what someone was talking about. A probing question is very similar to an open question, but gives a direction on something you want to hear more about. So the example I have here is, you said your cat is friendly. How so? Right, so here I give them a prompt, right? Their cat is friendly, and I'm then asking an open question about it. So your cat, how so? Multiple choice questions is providing a few different pathways to talk about. Or providing a few different options for response. Some people really respond well to this especially if they're getting overwhelmed. So, or they're having a hard time figuring out what they're feeling or what they want to talk about. So sometimes when people go through this, they feel sad, other people feel angry, which applies to you. So you see I gave sad and angry as an example. And then finally, closed questions are those yes/no questions. So this can be very helpful, especially if someone's worried about sharing. You can be like, are you comfortable talking more about this topic? So then you're deciding if you're going to open up that entire kind of conversational pathway. And if they're not, then you kind of change gears and figure out what you can talk about. All right, so we have an example here. We talked a bit about how to approach this, and we decided the video because there are really good examples of open-ended questions. This is all online. This is all under the umbrella of, it's called motivational interviewing, or motivational enhancement therapy is another name for like a similar concept. And I really encourage looking this up because it is very helpful. So what I'm going to do is I'm going to click into this video. It should share it with the audio. We're going to just watch a bit of it. Full screen it. And like I said before, if you want to watch the whole thing, I do recommend it. The link is in this, so you can find it fairly easily or look it up.
And then we just talked together about that. So, but I always like to just start with wherever you would like to start as well. I am setting the focus, the agenda, but also providing flexibility for Sarah, as I want to see where she wants to begin with the feedback. Had she just asked me to begin by giving her the feedback, I would have done that. But note that when I let her decide where to begin, I reinforce her autonomy and ability to self-reflect. It also allows me to hear her reaction to the questions she answered and hear if there is any concern on her part. I demonstrate that I am partnering with her.
Yeah, I mean, like, when I was doing those questionnaires, it was weird because, I mean, I guess I don't really think about, like, you know, like, drinking being, like, this huge deal, and I don't ever really think about, like how much I drink, and, like, filling out, like, how much I'm drinking every day was, like, whoa, you know, like, I just didn't ever really think about it, like, that I was, like, if I try to actually count the drinks, it's kind of a lot. I mean, it's kind of a lot.
You were pretty shocked at what you learned about your patterns. I use a complex reflection to emphasize Sarah's beginning awareness. Complex reflections pick up on the emotional impact for the client. They are deepening of the client's own self-reflection.
All right, so I'm going to pause it there, just because I think it kind of enough of this video has been watched that it emphasizes like what the structure is, and I do really like that you not only see the clinician use the skills, but you also get the rationale behind it, and I do think that these skills are useful also with family and friends too. It's just a helpful way to talk to people. All right, so we're going to go ahead to the next one, and I believe I'm passing it off here to Hasad. Okay. Oh no, this is me. I'm sorry. All right, so we're in the next one now, and the next kind of micro skill or section of skills is education for the patient and for yourself. And as I said before, I'm just going to go into kind of deeper detail here. Individuals are always going to be experts in their own lives. I'm going to go into deeper detail about that in a second, but first I want to emphasize that although a patient is an expert in their life, the practitioner is always going to be an expert in the medicine that they're bringing in. And so it's really about creating intersectionality and nuance and meeting the patient in the middle, where they're an expert in the unique kind of context of their lives, their intersectional kind of identities and experiences, and then you're bringing in a new kind of area of expertise and experience in how their symptoms and experiences meet the medical model, and you're using that to build out a treatment pathway that's unique to them and the context of their lives. And so, as I said before, the patient is an expert in what symptoms they're having, and how they experience those symptoms, right? A lot of people can have a headache, a lot of people can have withdrawal, but what they notice when they're going through withdrawal, what they notice and how they experience a headache is unique to them, right? They're also going to be able to tell you what their personal goals are, what they want to work towards, as well as what they experience as a barrier. The same people or different people are bothered by different things and experience different things as barriers. And so if you want a treatment plan to be successful, it highly encourages the success if you define success in a way that relates to that specific patient. They're going to want to work towards whatever success means to them. For some people, that's, seeing their children more. For some people, that's getting a promotion. For some people, that's losing weight. So it's unique. All right, and as a clinician or as someone bringing in another area, say that your loved one is experiencing this, but we have practitioners as the example there, you're going to adapt that person's experiences and their symptoms to the medical model or the support that they're looking for. If you're a clinician that's building in medical information, it's moving towards treatment plans. And in general, it's providing increased context. They come to you with the symptoms and goals, and you contextualize it with what your expertise are. And then the final kind of union of those two things, importantly, remembering that stigma is one of the biggest barriers to treatment. So that's why it's really important to encourage them to open up and share their goals and barriers. And it's really helpful to educate yourself as to what the unique barriers might be for patients, because then you can move it along and get them into a unique treatment plan and a unique kind of series of goals and ways that what they want to work on will fit into their lives that is unique to that patient. And the last point here that I really want to emphasize is that recognizing that the literature and what you can find online is not always going to relate to the specific person in front of you. The different identities are not a monolith. So someone might have a completely unique and individual experience of something. And so the only way that you really find that out is by asking and working with them. So it really emphasizes why this is helpful. All right, so let's move to the next section. And this is what I'll be passing on to Hasad.
Yeah, so patient-centered care that can include listening to patients describe their lives, using patient descriptions to establish goals and framework for their treatment. And consultation is speaking with peers or specialists in subject areas. And then need-specific resources is seeking out specialty resources on populations. So you see to our right, the American Psychological Association has some good guidelines for working with specific populations. This example, guidelines for psychological practice with transgender and gender nonconforming people. And then you have the other one for working with people who are unhoused or experiencing homelessness.
Great. Awesome. Yeah, and those are the different kind of ways that you can educate, right? So one is, consulting with peers and specialists. And then, as Hasad said, these resources exist and they're out there if you want to seek them out, in addition to speaking with different people who are experts. All right, let's move to the next one. I believe I'm going to pass this. Am I going to pass this on to you, Dr. McKinney?
Yes, I can
Okay,
share our
wonderful.
materials. So as I mentioned very briefly in our introduction, we do have some materials that can use after reviewing this town hall video. If you'd like more information, there's a link here on this slide to our website and a quick snapshot of what you might encounter on there. So we have a variety of resources. These are for individuals, for families, for practitioners. There are so many different things. We have some videos, public service announcements. We have some resources in the local area for things like treatment and legal help. We have also on there some self-assessments if somebody wants to take a look at symptoms they're experiencing to see, how they kind of relate to other people based on the norms of these measures. So we have a really wide variety of resources. We do encourage you to utilize them.
All right. And this is our last section where we can have a bit of a conversation about the different ways that these intersect with each other. I do realize that we are short on time, and this is to the remaining time. So let's talk for about 3 minutes. And as before, feel free to pause this when after I read this question and reflect on it yourself, or feel free to pause it after and kind of riff off of what the three of us talked about. But this question, the first part is, these concepts are useful in theory. Was there a time that you used these skills and how did it work? And do these skills need to be troubleshooted or used in combination? What happens when a patient doesn't seem to fit or respond to a skill or resource? So do you guys want to open this one up, or should I?
I can speak to the last question there. I know I've experienced working with some clients and just some people in my own personal life where the method that I'm using to talk to them doesn't seem to be fitting. They're not really resonating with it. And sometimes it's due to just their state of mind emotionally. It could be due to cognitive abilities. So sometimes I have to modify the way that I ask questions or share information. So for example, we talked previously about things like open-ended questions and reflections. And for some people, those are really useful, but there are other times where people might not be in a place to respond to those open-ended questions. And so in situations like that, I sometimes have to alter the way I'm asking questions and might ask more of those directed yes or no questions or multiple choice questions, just based on the person that I'm working with.
Yeah, after I learned about the APA's guidelines on working with different population groups, I've gotten accustomed to actually going and looking for those and self-educating myself so that I can make fewer microaggressions in clinical situations.
Yeah, I think those are both very good examples. And I think Hasad, with what you were saying, it's like, why rebuild the wheel, right? If these exist and you can educate yourself, and it saves kind of time clinically, it's very helpful. I know I definitely, and so motivational interviewing was the first thing I was ever taught in, and it's definitely the backbone of my practice. And like Dr. McKinney was saying too, you really do have to adapt to the patient in front of you. Some people, you kind of toggle between. Some people, for certain situations, they respond well to very open-ended questions. Sometimes people get overtaxed or tired, or a series of questions has really been intense for them. And so in that case, dipping into a closed question can be very helpful and can give them a little kind of freedom, and save their resources for another kind of area. I think you see, and also, I mean, with the defining the unique success and barriers to the patient, that's where you find harm reduction, right? Some people want to fully quit, some people don't. Thinking of an example, I had a patient who wanted to focus on like masturbation, and he wanted to fully quit, and that was his goal. And so that's kind of what we worked on, and then we adapted and changed it as we met. So I know that our time is just about ending. Our last section here is just to thank everyone. So thank you so much for attending this town hall. I'm going to go ahead and stop sharing unless, do you guys want to say thank you too? And goodbye.
Thank you so much.
Yes, we appreciate it. And when we send this out, we'll include our contact information in case you have any follow-up thoughts or questions. And we definitely are happy to chat about any of these issues or anything else we could help with.
Perfect. Thank you.
All right.
And I am going to, how do I stop recording?